Hello and welcome to Pain in the Podcass, your place to find out everything you've ever wanted to know about pain. My name's Dr. Joseph Parsons, and I'm joined by the wonderful Don Wijasoria and Dr. Joshua Craw. And today, we're talking about pain after a stroke. Welcome in. Hello and welcome to Pain in the Podcass. Today's episode is going to be about pain after a stroke. But before we get into that, let's find out some facts and learnings about ourselves. So let's start this week with Josh.
So my fact for the week is I absolutely hate wool.
What kind of wool? Like
really scratchy wool. Do you know, like in a thick blanket that's just really scratchy?
Yeah.
I hate it. Like, it just makes my skin crawl.
Yeah.
And do you know how we found this out?
How, Joe?
My mother-in-law bought us a Christmas gift, which was a lovely woolen blanket.
It looks beautiful.
And Josh has been using it and then moaning about using it throughout the weekend.
It's just shed everywhere on me.
It has.
Yeah, he was wearing some dark blue joggers, and it looked like he had just had a cat roll all over him.
Yeah, the joggers were twice as thick by the time he took the blanket
Yeah.
off.
Yeah, nice and warm, but like...
Hey, it was a cotton wool blend.
Oh, is it?
Well, his
It was
joggers are now.
Oh, the joggers are, yeah. How about you, Don? What's the fact about you?
Fact about me is that the oldest pair of shoes I own are 12 years old.
And are they still, doing the job? Are they still...
Yeah, they are, yeah.
Are they talking
not that
to
I
you?
wear them,
Okay.
but they can still be worn.
What are they?
Just some, dress shoes. Black dress shoes.
And you've not worn through them in 12 years? Do you have another pair of black dress shoes?
Yes, I do, which
Oh,
are much
okay.
better.
It's only worn them 4 times.
Yeah,
And
exactly.
also, yeah. How often are you wearing dress shoes?
Relatively often.
Oh,
but
that's
you
because you're
dance.
fancy, yeah.
You dance.
But even then, I don't wear them for dancing. I've got separate shoes for dancing. I wear them to weddings. I wear them to...
Yeah, but you're in a
events.
relationship. You go to weddings every week.
Yeah.
Not ever. I've only been to 3 in the past few years. Not even that. 2.
Also, you're a devout Catholic who goes to church every Sunday and has to wear a Sunday best.
Yeah, that's definitely me. Definitely me.
Yeah.
Although for a long time was me. Well, I wasn't wearing my Sunday best. I did go to church for a long time, but I don't anymore. There you go. That's a fact about me. I no longer go to church. There you
Wow,
go.
that was easy.
God's crying.
Josh, you must be
Well,
jealous.
maybe. I won't voice my thoughts on Catholicism. I think that's only I think that faith is a great thing. I think religion is more challenging. Let's leave it at that.
Well said.
Josh, what have you learned about yourself this week?
I've learnt that I hate trains again. I just hate trains. I just hate trains.
Trains hate you.
It took me 4 hours to get up here, and it's going to take me over 7 hours to get home.
That's the commitment to this podcast.
7 hours.
Yeah.
There's just nothing to do.
Yeah, but you can watch a film, you can watch
Read a
TV,
book.
you can read a book.
But there's always 200 people connected to the Wi-Fi, and it goes like a snail.
Download it.
Yeah, you download things.
Oh, I could download it. What do we download? Oh, God.
Well, I didn't mean now, but yeah, sure, go ahead.
Yeah, sorry. Guys on the podcast are going to have to wait for 3 hours.
Well, while Josh does that, Don, what have you learned about yourself this week?
I've learned that I might also have a similar thing to Josh, where he hates
Well,
the feelings of fabrics.
Okay.
The one that I do remember hating a lot was the feeling of swimsuits, mostly the Speedo types.
Okay.
Like from when you were
Lycra.
younger.
Okay.
Like Lycra, yeah.
oh,
Really didn't like that.
They're scratchy
Yeah.
as well, yeah.
They're not scratchy, I just didn't like how sticky they were.
Oh, it's all sticky.
I mean, you just didn't need to. You could have cleaned them first.
Okay.
Speaking of Lycra, remind me later on, but Lycra actually will be quite relevant to this episode. There's ways that you can use Lycra in stroke patients.
Oh, okay.
Other than to make them look fabulous.
Right.
But you can actually use Lycra as part of the rehab process.
Speaking of rehab, I guess, I don't know if this is classed as Lycra, I think it's more silicone, but you know the material that bands are made out of, what are they called
Latex?
again? Latex?
Rubber?
Elastic rubber? Yeah, I don't like that either.
Okay.
It just gets dusty, and I don't like the feeling of that dust on the actual rubber.
Yeah, to be fair,
Gets dusty.
rubber bands get a very specific kind of dusty. It feels like talcum powder almost.
Yeah.
Is that dust? I thought it was just I thought it was the elastic degrading because of sunlight damage.
No, it
Oh.
could be that as well.
Maybe. But yeah.
Speaking of elastic degrading because of sunlight damage,
Overstretch.
do you know that in certain NHS trusts, if you want to give out resistance bands, you know, like the things you use for exercise,
Yep.
if you give them out, you have to get people to sign a proforma to say that you've explained about the risks of using resistance bands, to tell them to not use them if they've got any like cuts or snares in them, to not use them if they've been kept in direct sunlight. If the coating has rubbed off, you have to cover it in talcum powder and stuff like that, because apparently it's a risk that it will snap into your eye.
Damn.
So a lot of them have banned it. You've banned giving out resistance bands in MSK departments unless you've done that. Risk assessment.
Yeah, and I went when I was doing my knee rehab. My physio told me this, and then she went on to tell me what else they banned, and it was something ridiculous like kinesiology K-tape.
Yeah.
And so one of her other patients had donated a couple rolls, and she was using that on her patients.
Well, the evidence base for it is basically none.
Yeah.
So, I mean, I'm not surprised that it doesn't need to be banned. It just needs to be less promoted. All it really does, the current evidence says, is it gives you a little bit of feedback of sensation to know where your joint is in space. But actually, I mean, if you've got ligament issues with your knees, for example, having a little bit of tape around it isn't going to fix the internal weakness.
So you mentioned that these bands having snares in them, you can't use them.
Yeah.
So if you hear a then you should stop, yeah?
Yeah, that's exactly what it means.
Yeah.
It's the low-hanging fruit for Josh, isn't it? It's the dad jokes.
Moving on to the meat and potatoes of the learning. Joe, what have you learned?
For context, for those of you listening at home, Josh did just try to move on to the rest of the episode before my learning with the meat and potatoes of the episode. So there you go. I learned from a conversation with a colleague that apparently grip strength correlates with a lot of different health outcomes. So if you've got lower grip strength, it's associated with higher risk of cardiovascular disease, disability, cognitive decline, and death. And the reason why I learned this was because I actually have really quite poor grip strength compared to my colleagues, and so I have bought grip strength trainers because I'm worried that I'm going to die.
Oh, gosh. Do you know how much grip strength you lose if you lose your little finger?
No. I'm going to say 35%.
I'm going to say none.
I thought you were going to say 36%.
No, because I'm not a twat.
50%.
Really?
50%. It's
To be fair, I can see that.
It's the most important.
Yeah, thumb and little finger are the most important things for your grip, I guess.
I did think it was significant, but part of me also thought that you might be throwing a curveball, and so I said 0.
I like that.
Makes sense.
Always makes you second guess yourself, doesn't it?
Yeah.
It does, yeah. Joe gets the point on the leaderboard.
Woo! I'm not sure.
Howler train.
Not sure. I'm not sure I deserve the point for that. But Josh, do you want to?
Yeah, so moving on to the actual meat and potatoes of the episode. Let's start talking about a stroke. So, other than a gentle caress, what is a stroke?
So a stroke is a loss of blood supply to an area of the brain. And so if you lose blood supply to any part of your body, then you will end up with damage because you're not getting oxygen and you're not getting nutrients to this area. But obviously with the brain regulating everything that we think, say and do, this can have some really quite dramatic effects.
Yeah, and it's a very high mortality sort of illness. So approximately 7 million people a year die from strokes.
Worldwide.
Worldwide, that is, yeah. And globally, it can cost up to like 890 billion with a B dollars globally.
With a D.
With a D?
You said dollars.
Oh, dollars. I thought it was like globally. It's definitely with a G. But yeah, that's in costs like the medical treatment of the people and the rehab of them, the costs in lost productivity. Like, it's a huge impact on the global economy. But when we think about strokes, we speak about a loss of blood supply, but there's two kind of most common ways, aren't there, that you can lose blood supply to an area of the brain?
Yeah, there are indeed. So the most common, which makes up about 87% of strokes, is the ischemic stroke. So ischemia meaning sort of death from lack of oxygen. So there is a blockage, so a clot that goes through the circulation, goes to the brain. Now, when that clot goes to the brain, the vessels get smaller, so it'll eventually get to a point where it blocks. So it plugs up an area. And everything distal, so away from that blockage, has now not got as much oxygen as it normally would, unless it's got collaterals, so like other vessels providing it with oxygen. So that then starts to die. It's the most common, and it's fairly treatable, but nobody wants this. The second type is hemorrhagic stroke. This makes up about 13% of strokes, and this is from typically like a ruptured vessel, so like a bleed in the brain. And what this does is, blood is very toxic in terms of brain tissue. So it can actually directly damage brain tissue, but you've also got this bleed, so less blood is going to where it should be going to. And this is less common, and you might have treatments like trepanning, you might need neurosurgical inputs for this. And one of the important things is, just because if you have one or the other, so if you have an ischemic stroke, it can actually transform into a hemorrhagic stroke. So we do see, after people with ischemic strokes, they can have what we call a hemorrhagic transformation. So, yeah.
So that's the idea that the tissue that has been damaged by the ischemic stroke, due to sort of the increased immune activity, due to the lack of oxygen, due to inflammatory enzymes, that tissue is then weaker and so is more vulnerable to starting having bleeds. And so usually, I say this sort of rule of thumb, the bleeds from a hemorrhagic transformation don't tend to be as dramatic as a full-blown hemorrhage, but they do tend to sort of present with additional features on top of the original ischemic stroke clinically.
Yeah. And you've been working in a stroke unit currently, haven't you, Jen?
At the time of recording, yes.
Do you see any difference in terms of patient outcomes, discharges, and patients' journeys, differences between hemorrhagic and ischemic strokes?
Yeah, I mean, the majority of patients, obviously from statistics that we get on the ward, will be ischemic strokes. But as a rule of thumb, hemorrhagic strokes tend to present with greater levels of clinical deficit. So that means sort of them cause a greater effect to people. So it might be they've got more weakness, it might be they've got more difficulties with their swallowing, with their speech, with their coordination. And the evidence says that people who have hemorrhagic strokes end up staying in hospital longer and usually require more assisted nutrition. So that means they can't eat normally, maybe because their swallow's been affected, maybe because their ability to feed themselves physically has been reduced, or their cognitive ability to remember to eat. So that might be something like a nasogastric tube, so a tube that goes up your nose and directly into your tummy, where you can be fed liquids, or things like a PEG, which is a similar thing that goes directly into your stomach.
Oh, that sounds nasty.
And so, Don, how does a stroke present then? What are the kind of signs that someone's having a stroke or has had a stroke?
So there's something called the FAST campaign, and this stands for face, arm, speech, and time. And so that means, so if just checking what the face looks like, if there's any drooping, any signs like that. Arm, if one arm is heavier than the other. Speech, if there's any signs of slurred speech. And time.
So that's get people to a hospital as quickly as possible if you're seeing any of these symptoms. If you have a suspicion that someone is presenting with these, if you want to know if their face is drooping, ask them to smile. That really exacerbates, or not exacerbates, but makes it very clear if someone's got a drooping face, because if one side comes up into a normal smile and the other side stays where it is, gives you a sign that there's this sort of loss of function on one side of the face.
Asymmetry.
Ask them to lift their arms above their head. If one or both arms, obviously if they've got shoulder issues and stuff and never could before, it's not a great measure, but if previously they could move their arms freely but now they can't get one or both arms above their head. Speech, does it sound that they're struggling to coordinate it? Is one side of their mouth moving less than the other? These are kind of ways in which you can implement these elements of the FAST campaign into spotting whether someone might have had a stroke or not.
And it's not just these things. These are the things that people think about most. So the slurred speech, drooping face, arms. But vision can be affected. So if a part of the brain, the visual cortex, is affected, then you could have loss of vision. Like you could have double vision, blurred vision. You could have what we call hemianopia, which is where you lose like half the vision. So you lose your peripheral vision, for example.
But that's in both eyes. So some people who have hemianopia, imagine that you lose the left half of your vision in both your left and right eyes. And so it can be really difficult for people because they just have one half of the world that isn't there. If you look at hemianopia and eating meals, you'll see that some people who have hemianopia will start and they'll eat half of their food and they'll leave half the plate empty because that side of the world doesn't exist to them unless they turn their head round. So if they've just been eating normally, you'll see that half their food goes untouched. And so if you then turn the plate round so they can see the other half, then they'll carry on eating. But otherwise, they just won't have any recognition that that part of the world exists.
Yeah, we kind of went through that on my psychology course, and it was interesting to see that sometimes they won't even attempt to think about the other side because they have no perception of it. Whereas for us, I feel like if you can't see something, you're still curious about looking at it or finding out. Whereas there were cases where they just completely disregarded the other side.
Because it's like the brain, if it's got reduced sensation, another effect of stroke, if it's got reduced proprioception, so awareness of where your body is in space, and reduced visual input, like they're the things that make you realise that your body exists, right? If you can't see it, you can't feel it, and you've got no awareness of where it is in space, then of course your brain's just going to start forgetting about it.
So that visual thing and not like doing that, we call that neglect.
Yeah.
So like you're neglecting that like entire part of the existence. It's like you get people that shift half the face.
Yeah.
Wow.
And so we'll touch on this a little bit more about how that gets managed later on, but
surely,
just important to think about.
Sorry, just going back to the shaving of the face, but surely they know that the rest of their face exists. Like that's the
But the brain
thing.
doesn't necessarily. That's the problem. Because
Yeah.
if you're only seeing half of it, it's hard. I can't imagine it. It must be really difficult to live like that because no one will really understand what you're going through.
And also in terms of the vision and the neglect, like we was talking about, there's a syndrome called Charles-Bonnet syndrome, which is where your brain's effectively just chatting shit to you. That's the best way I can think about it. So it just starts like hallucinating really vividly. So you start making up things.
So your brain is basically filling in the gaps from where you've lost vision by making you see things. So it's not that you're making things up. It's not sort of like a psychological disorder. It's your like vision centers in your brain telling you, well, we can't see anything there, so we're going to fill in the gaps. Because you actually do that all the time anyway. Your peripheral vision, a lot of it is made up from your brain telling you, well, before when you looked over in that direction, you saw Don on your left-hand side. And so your brain now helps to build that picture of what he should look like in your peripheral vision.
It's fucking ugly.
And so, yeah, Charles Bonnet is kind of a dramatic version of that. I've had patients who have thought that one half of the room was on fire, which is quite distressing. But then I've had other people who have said that they've got cats everywhere. You know, it's sometimes it's quite scary things. Sometimes it's very mild and quite sweet things, actually. One person saw their father, who had passed away a long time ago, saw them quite vividly in that side. They couldn't hear them. And that's a good way you can differentiate as well from other hallucinations. Often with hallucinations, you'll have an auditory element as well, where you're imagining a sound, but Charles Bonnet only presents with visual hallucinations.
Isn't that where dogs can be helpful in terms of not treatment but management, where it's like a therapy dog, I guess, and it will help identify if what the person is perceiving is a hallucination or not?
I don't know.
Have you
Tell
not
me
seen?
more.
Oh, I've seen little videos of them
Yeah,
where
the
the person
dog just comes and says, "Oh, that's real."
yeah. So the dog will look at the thing to confirm that what you're seeing is real. If it's a hallucination, it will obviously not see it.
Oh, so you mean like, so say if you thought the building was on fire, the dog isn't just going to be like, yeah, dude, it's chill.
Yeah.
The dog will also be going,
Exactly.
this is, okay, yeah, I've
but
not
like
heard of that.
on some of the videos, the person who's hallucinating will tell the dog to go and greet that person that they're hallucinating, and the dog just looks over there and is like, bro, there's no one there.
Oh, that's so interesting.
Yeah.
I've not heard of this. Thinking about that kind of vision loss as well.
Well, what if the dog's a hallucination?
Oh, God. Thinking about that loss of vision as well, what you might see quite interestingly if you meet people with strokes, sometimes when they've got this hemianopia, they've got this loss of vision to one half of both eyes. You might actually see that their eyes can't actually move beyond the middle. So say that they've lost the left half of their vision, you might find that they cannot physically move their eye beyond the middle of the centre of their eyeball. They can't keep on scanning to the left-hand side because their brain has just lost the ability now to move the muscles that allow your eyes to move. So it can be quite a clear sign that goes alongside that loss of vision.
Yeah, and regarding the FAST campaign, we mentioned speech. So speech can be affected. You can have something called dysphagia. So you can have expressive or receptive dysphagia. So expressive dysphagia is where you can still fully understand people, but you're struggling to get words out. So you might have very slow or halted speech and difficulty in word finding, for example. Whereas receptive dysphagia, you're very fluent. We call it a fluent dysphagia. So you're talking utter gobbledygook, and your understanding can be affected.
Right.
But speech can also be affected by things called dysarthria and apraxia. So dysarthria is an actual weakness of the muscles involved in speech. So that tends to be, when we think about that slurred speech presentation, that's the kind of thing that you start to see. And apraxia is that the muscles involved in speech aren't actually weak, but it's the coordination of them that's quite difficult. So you might have heard of people being dyspraxic. So that's when they sort of have poor control of their movements. They might be quite clumsy, dropping things a lot. So this is a dyspraxia of the mouth. It's that inability to coordinate the movements properly to speak, which can present similarly with words that don't quite sound right. It can be slurred, or it can be mispronounced, or something like that.
Yeah, and so as you can imagine, if you've got a drooping face, your speech is affected. Your swallow can also be affected. So you could have dysphagia. That's dysphagia, not dysphagia.
So with a G rather than an S.
So that increases your risk of aspiration, so like accidentally breathing in or inhaling food, saliva, which can cause life-threatening infections.
Yeah. Along with that, coordination and fine motor control could be affected.
Yeah, absolutely. So you might not be able to use a pen anymore, for example.
Your personality and executive functioning could be affected. So that can include things like decision making and memory as well.
And obviously, alongside all of this, mood is going to be something that is commonly affected in a stroke. And there's two major reasons for this. One of them being that when you're aware of the kind of deficits that you have, that can be very traumatic because your life has completely changed compared to prior to the stroke. However, there's also an element of the fact that mood processing centres in the brain can be damaged and cause them to malfunction. So you get something called emotional lability, which means that people are very labile, very changeable in their emotions. So you might be working with someone who you tell them a joke, and without being able to control it, they're hysterically laughing, absolutely as if it was pant-wettingly funny, and they'll burst into tears. And they don't necessarily feel sad, or they aren't aware of feeling sad, but their emotional control is just really affected by it. And very interestingly, your things like laughing or coughing or sneezing all can increase something called tone, which we'll touch on a bit more later. But sometimes you might see people where their arm is kind of drawn up towards their chest, so they've kind of got a bend at their elbow, a bend in their wrist, their fingers are all curled in. That's an example of high tone that might happen after stroke.
Yeah, we call those contractures, don't we?
When you can't move them, yeah, when they get stuck in that position. But we have a patient who I've worked with who every time he laughs, he gets really high tone. So you might have his arm really relaxed and by his side, and someone tells him a joke, and immediately his hand curls up right up to his chest.
That's kind of cute.
But also very annoying for him.
Yeah.
So I have to try and be as blunt as possible. Not blunt, but kind of neutral around him as possible so they don't make him laugh too much.
Should we move on to the risk factors for a stroke?
Yes.
Yeah, I think, 90% of strokes are attributable to modifiable risk factors. So that's things that you can change. For example, alcohol intake, smoking, hypertension.
Yeah, so that would be high blood pressure.
Atrial fibrillation.
Do you want to quickly touch on what that is, Josh?
Yeah, so it's where the atria, so the top of the heart, is fibrillating. So it's sort of like contracting out of time with the ventricles, so it makes your heart rate irregular. And because you have an irregular heart rate, it increases like the lax blood at the top of your heart. So if you imagine in a river where you have eddies, where you've got swirls of slack water almost, what that does is that slack blood, where there's not as much flow and it's not all nice and even, that increases the risk of you forming clots. So then you can send those clots off through your veins, through your arteries, and then they can go up to your brain.
Yeah.
And other things that are associated with that increased risk of clots as well are things like obesity, high carbohydrate intake, consumption of red meat. All of these things seem to be associated with this increased clot risk.
I'm a walking stroke risk.
And let's not forget diabetes as well.
Yeah.
Diabetes.
But these are kind of risk factors that you can think about changing yourself if you're having a listen to this, like reducing your alcohol intake, stopping smoking, trying to have a better diet. But thinking about protective factors against stroke, what can you at home be doing to try and protect yourself against having strokes in the future?
Exercise. I guess.
I mean, in this context, it's one of the fantastic benefits is exercise can decrease your risk of stroke.
Yeah. And it can also help to reduce hypertension as well. So that, alongside other hypertension-reducing medications, can be really valuable. And so, yeah, if you can get a drop of 10 in your systolic blood pressure, so your blood pressure when your heart's contracting, and 5 when your heart is more relaxed, then you can reduce the risk of strokes by 41%.
41%?
So it's a really big drop-off.
Can you just say 10 and 5 of what?
So this is the reason why I didn't mention the units. It's millimetres of mercury. So effectively, millimetres of mercury is a way to measure pressure. And so the pressure that is produced in your heart, you might have heard people say that normal blood pressure is 120 over 80, and that is millimetres of mercury. And so you're looking, if your blood pressure is above 140 over 90 millimetres of mercury, you're classed as hypertensive, and so you're looking to drop that by 10 of the higher number, the systolic blood pressure, and 5 of the lower number.
Unless you look at the most recent American cardiology figures, in which case they actually have lowered the threshold for hypertension now. It's a very good question that we'll talk about in the breakdown.
Okay.
And so preventing strokes, particularly after you've already had a stroke, so secondary prevention, is things like statins, so like atorvastatin, simvastatin, rosuvastatin, those sorts of things. They reduce the risks of ischemic stroke by 17%.
Another kind of drug that can reduce your risk of having a stroke is aspirin, but because aspirin thins your blood, it does reduce the risk of ischemic stroke, so the one associated with clots, by about 20%, but actually it increases your risk of having a bleed because your blood's thinner, so your risk of hemorrhagic stroke increases by about 10%.
What I would say is, technically, Josh is pushing up his glasses here, aspirin isn't a blood thinner, it's an antiplatelet medication.
Which reduces the risk of clots.
Correct, but doesn't thin the blood. You can use blood thinners, what we call oral anticoagulants. These are very common to treat atrial fibrillation. So what that does is that thins the blood down. So like what I mentioned earlier with the slack water analogy, it thins the blood so there's less likely to form the clots that then go off and cause strokes.
And particularly when you've got people who've already had a stroke, the risk of stroking again within a year is 10%, and by 10 years it's up to 40%. And so one of the biggest ways you can prevent repeated ischemic strokes is to use these anticoagulants. They're very prevalent in the secondary prevention, so preventing it from happening again.
And so would you start taking those immediately after recovery from the first one?
Well, what I would do is I would take whatever advice a stroke consultant tells you at the time, because as with medicine and everything, this can all change on a dime.
Yeah. So for some people, even though they've had an ischemic stroke, you don't necessarily want to pump them full of anticoagulants because that might increase the risk of what we spoke about before, that hemorrhagic transformation. So it's going to be down to that consultant on a case-by-case basis to work out what's appropriate.
What we do as well is we do risk-reward sort of stratification as well. So in some people, there may be very high risk of having anticoagulants. So let's say that you're at significant falls risk. Well, if you fall and hit your head whilst you're on anticoagulants, you can have a significant brain bleed. So if you're falling every single day, is it actually worth putting you on an anticoagulant?
Yeah.
These are things that one's doctor would have to weigh up and have a chat and discuss with the patient.
Yeah.
But other than exercise, all we've really mentioned there are things that your doctor would have to be involved in, so things that you can be prescribed to help reduce your risk in an appropriate circumstance. But actually, diet can have a big role in preventing strokes. And so what sort of things can you do with your diet to try and reduce the risk?
Yeah, I think, Don, you looked at this in a bit more detail, didn't you?
Yeah, so as with many things, fruits and vegetables are always a plus. And the wonderful Mediterranean diet, recommended for so many things. Folic acid supplementation, fish is always a great one. Vitamin D, making sure to get vitamin D and vitamin C. And, this is fun, chocolate.
Oh, yeah.
I was very surprised to find this out when we were reading about for this episode, that chocolate does seem to be protective. I'm sure there's a balance to be had, in the same way that people say red wine's good for your heart, but the amount you'd need to drink, it then becomes harmful to your liver. You know, there's a balance, but chocolate itself does seem to have a protective effect against stroke, surprisingly.
So, did you know that alcohol in no quantity is good for you?
Wait, what?
Alcohol in no quantity is good for you, as in any amount of alcohol is not good. So people think, oh yeah, if you have a couple of drinks, then it's actually protective for the heart, but it's actually a common misconception. The studies that people are citing there, they're citing them incorrectly. So it was on heavy drinkers, so people that were heavy drinkers already.
Yeah.
So if they only had 2 pints as opposed to 10. So we see a J-shaped curve, so it looks like having a small amount of beer is beneficial to heart outcomes, but actually it isn't.
I think my mum, who gives me brandy whenever I have a stomachache, would disagree with that.
I would not want to disagree with Mrs. Woodger,
Yeah.
You make it sound like she's terrifying.
But no, she's not a drinker. She's definitely not. She doesn't really like alcohol. But it's one of those things. I don't know if you guys, if parents, families, you do this as well. But brandy was always like one of those things that you'd have whenever you'd have like a stomachache.
As a child or as a...
Even as a child, yeah.
Oh,
they just
yeah,
give you a
not
little
for me.
spoon of brandy.
No, I mean, I think there's like a tot of whiskey. That's the sort of thing.
Like a toddy or something.
I don't know. I've never heard of this before.
Yeah, you never had a
I've
hot
heard,
toddy?
I know what a hot toddy is, but I've never heard of it being used for a stomachache.
Yeah.
I don't know if it's just for stomachache. It's for something. I mean,
I was too drunk to remember, to be honest.
Yeah.
After all the brandy.
Yeah.
What was wrong with me again, Mum?
As a doctor, I wouldn't recommend giving people alcohol.
Yeah, I mean, I wouldn't recommend it either, but it's just something that happened.
But as a doctor, what would be recommended for the management of a stroke? So say that you or someone that you know has had a stroke. What are the different ways that it might be managed?
Yep. So it all depends on timing, which is why we say why T is in that fast mnemonic. Time is the most important thing. Time is brain. The longer you leave it, the more damage is going to be caused. It's like a fire. Like if you don't put the fire out, it's going to rampage through your house, sort of thing. So in the early stages, so like 4.5 to 6 hours, depending on the location, ischemic strokes can be managed with what we call clot-busting medications. So,
Sorry to interrupt you there, Josh, but you just said in the early stages, which could range from 4.5 hours to 6 hours.
yes, correct.
That still seems like a very long time.
If you think about it, you've had symptoms, bam, the clock starts.
By the time that you've had someone find you or has it made someone aware of the symptoms, by the time you've had an ambulance, you've got to hospital, you've been triaged, you've been taken into like an appropriate setting, whether that's a surgical setting or, it does take quite a long time. But the reason why it doesn't tend to go beyond that 6 hour window, or often in some places 4.5 hour window, is because if you imagine that this area of the body is being starved of oxygen, you start to get this inflammatory process that builds up and builds up and builds up and builds up. And then that part of the body is starved of oxygen. When you then flood it with oxygen, when that clot is burst, your body, because of the inflammatory process, instead of using that oxygen how it normally would, which is to keep it alive and healthy, it starts to use it to fuel that inflammatory process. And so you get things called reactive oxygen species, which are basically... maybe over-dramatising, but they're grenades in your cells. Your body's just throwing off grenades. It's just throwing loads of inflammatory shit out to try and get your immune system to help. But actually, in the short term, that damages things further. So the research suggests that this kind of 6 hour window, if you use these clot-busting drugs beyond that, actually the damage that occurs as a result is worse than the benefits of getting rid of the clot.
Yeah, absolutely. So I mentioned clot-busting medications. So those are really fast-acting blood thinners, which dissolve clots effectively. Well, I say effectively, they can dissolve clots effectively. There is some contention between clinicians, and different stroke consultants have different thresholds for when they would use thrombolysis, because it is risky. Like, as Joe mentioned with hemorrhagic transformations, if you give somebody thrombolysis, they can have a massive brain bleed. This is why it has to be a specialist that prescribes this type of medication. You can also have surgical interventions, such as thrombectomy, which is where we go in and we grab the clot with a little mechanical arm and suck it out effectively.
Yeah. Am I right in saying they often go in via your groin? They go in via one of the veins or arteries in your groin. I think they send a tube all the way up and they feed it through your blood vessels. I think it's got a camera.
I'll be honest with you, I don't know exactly which vein or artery we do, but you can go over the femoral to go up to your carotid, so I imagine that's
the one, I think.
When you say go through your groin, do they just make a new hole or use an existing hole?
Oh no, not through your urethra. Through a hole in your... Yeah, sorry, through a blood vessel in your groin. Through a major vessel in your groin,
so
feed the tube up.
You may have heard your femoral artery or femoral vein, or your femoral vein. You can go all the way up.
Yeah.
Because it's a big, thick vein.
Sorry,
artery.
no, it's just when you... I just don't associate little teeny tiny vessels with... I mean, you do, but... I'll just stop talking now.
I'll tell you what we'll do is in the breakdown we'll say which vessel it is.
Yeah.
So if you're interested, because I can't remember off the top of my head because I'm not a neurosurgeon. Yeah.
But if you were a neurosurgeon and you had a patient who had a hemorrhagic stroke, when you have bleeds that cause a stroke, what you can often have is build up in pressure inside your cranium, inside your skull. So it's a raised intracranial pressure, and to be honest with you, there's not really anywhere for the fluid to go. If it's all getting caught in your skull, your body's not doing a good enough job at draining that fluid. And so the best ways that we have might seem a little bit brutal, but there's kind of two key methods depending on the severity, aren't there?
Yeah. Trepanning.
You might have heard of this called boreholes.
So that's just getting a drill and drilling into your head.
Boreholes? Boreholes? Boreholes.
Boreholes.
Boreholes. Yeah. Drill a hole in the head. That allows the fluid to get released. What about in a more extreme example?
Craniotomy. Craniotomy or hemicraniotomy, which is where you effectively saw a part of the skull off to release pressure.
Yeah.
And then you can control the bleeding through that. But yeah.
And so you might see people after a stroke wearing rugby scrum caps. And the reason for this is because they're lacking a skull on part of their head. To protect that area of brain tissue that's underneath the skin, they put a cap on. I'm not sure how much good it would really do if you fell onto that area of your head, but maybe it's just a warning for the people who are with them to be careful around their skull, or maybe it does help, I don't know.
Or maybe it's like infection control as well, sort of like trying not, because you don't want an infection in there, so that just like secures everything there so you can't like accidentally scratch off the dressing or...
Possibly,
Who knows? Not me.
Not me.
All I know is that when you told me about, when you mentioned the skull cap thing, my legs just turned to jelly. You know that feeling of like losing control in your legs when you hear something?
Leg.
I was like, I don't know. I don't know how to describe the feeling, but you know when you hear something that you're really not comfortable with.
Oh, okay, what?
Squeamish.
Squeamish, yeah.
Yeah. Okay. I don't tend to have wobbly legs when that happens, or to do the stanky leg, but...
What is stanky leg? I need to have a look. Oh, I see. Okay.
But beyond this, whether it's treated with clot-busting drugs, surgery, whether it's treated by having parts of the skull removed, whether it uses these methods or not, it's then a multidisciplinary team, so involving stroke doctors, involving nurses, physios, occupational therapists, speech and language therapists, healthcare assistants. All of these people are then involved, and dietitians, sorry, I shouldn't forget the dietitians, are all involved in the management of these people's care beyond that.
Now, I mean, we've talked a lot about risk factors, about how strokes affect people, symptoms. Should we get to the crux of the matter and the main point of this episode, which is pain in strokes?
You mean the meat and the potatoes?
The meat and potatoes.
The meat and potatoes.
Meat and potatoes.
Well, depending on what study you look at, the estimates of how many people develop pain chronically after a stroke varies from somewhere between about 11% all the way up to about 67%, depending on which studies you look into. But either way, a really substantial number of people who are experiencing pain. And those who have higher pain ratings tend to be those who had worse strokes, so more severe strokes. Those who have reduced independence, so it's again, that correlates quite well with that more severe strokes. They've got more clinical deficits. And those who have higher ratings of depression and anxiety.
Oh, okay, yeah. So we've seen that as a risk factor for chronic pain with pretty much everything else, haven't we? Particularly when we did we do an episode on mood and pain?
We did. We looked at depression and pain.
Yeah.
Very interesting episode. Please go back and watch if you haven't already.
Something I found really interesting, though, was that the only kind of clinical symptom associated with consistently lower pain scores was aphasia. So you might remember before we said dysphasia, which means an altered ability to speak, whereas aphasia is an inability to speak. So it's unclear whether these patients that have this kind of type of stroke actually do have reduced pain, or whether this is just an artifact of their difficulties in communicating their pain, whether we're not kind of
that makes sense,
helping to understand the experience they're going through.
Well, I mean, we did an episode on language and pain, didn't we? So if your language areas are damaged, does that affect your processing of pain as well?
Yeah, it'd be interesting to know, wouldn't it?
Yeah, we've got so many research ideas.
And no money to research it.
Or time.
So then, we said that strokes can cause pain. What are the different ways in which stroke can cause pain?
Yeah, so one of the ways is central post-stroke pain. Basically, what's happening there is there's lots of different tracts in the brain which control all different sort of functions. So the thalamus, spinothalamic tracts, trigeminothalamic pathway, the lemniscal pathways. Oh, you don't need to know all these, but they're all different pathways in the brain which help you interpret sensation, including pain. And it's thought that damage to sensory pathways involved in pain processing lead to a compensatory overactivation of pain processing areas in the brain. So this leads to spontaneous pain, or allodynia. And allodynia is excessive pain sensation with a what would not be a noxious stimulus. So if I was to stroke your hand, for example, Dom, that might feel incredibly painful, like I'm sticking a needle in you.
And actually, to support this theory, there's decreased binding of opioids, so natural opioids, to opiate receptors in these areas of the brain, like the thalamus, the insular cortex, these areas associated with pain processing. And so it means that maybe your body's natural pain-killing processes are affected by the stroke.
Yeah, and this isn't something that we typically see immediately. Usually it's about 1 to 3 months after the stroke where we start to develop this pain. And one of the big factors is a history of depression, how severe the stroke was, being a younger age actually, and smoking. So these are all risk factors which we've talked about in the risk factors for stroke, but there are also risk factors for pain and after stroke as well.
So if you were to look at how the pain actually presents itself, it could present as aching, dull, sharp, or shooting, depending on the area of the brain that's affected. And it can be managed with antipileptic drugs, which have more of an effect on sleep, anxiety, and quality of life than the pain itself.
Wow, can we just have these if we've not had a stroke?
Well, but again, it's in the same way as these anti-epileptic drugs have previously been used in chronic pain management, sort of more generally. It's those effects on the other elements of your life that are its main target, and then as a result of better sleep, less anxiety, that kind of helps to bring that pain down.
Yeah, and there is some scant evidence to suggest that corticosteroids can give a short-term relief. So corticosteroids are steroids not like you'd build muscles with, but like what you'd do to reduce inflammation. So like when you're having like a flare of asthma, for example, this can reduce inflammation and can relieve pain, as I said, in the short term. But this isn't common practice. It's a sort of scant evidence towards it.
Yeah, and there's also a little bit of evidence that suggests that deep brain stimulation, so stimulating areas of the brain with electrodes, can provide some benefit. So sort of giving electric signals to areas of the brain, but it's not a commonly used methodology.
Ooh, we might talk about this in the breakdown, but I recently saw some electroconvulsive therapy. That's quite interesting.
Very interesting. We talked about that in our episode on depression when we were speaking about intractable depression, where we're saying when you just can't cure it with anything else, that's one of the methods that they use.
That's more than what would be deep brain stimulation. Deep brain stimulation is a very delicate tool, whereas ECT is a lot more broader, sort of blunter tool.
Yeah.
Invasive.
So that's central post-stroke pain, but also one of the things that can be particularly painful is spasticity. Now, a lot of you listening at home may have heard of the term spastic, and particularly heard of it used in a derogatory way. Spasticity, the word spastic actually comes from the Greek meaning to pull, and it only really started to get a derogatory meaning in the sort of 1970s and 1980s. Before that, it was what people with cerebral palsy called themselves because they presented with a symptom that we'll explain shortly called spasticity. To be very specific about when it started to be used in a derogatory way, there was a gentleman called Joey Deacon who lived with cerebral palsy, who had quite severe spasticity, who appeared on Blue Peter and talking about his life and his achievements alongside managing his cerebral palsy. And the word spastic was used to describe him in a non-derogatory way, but this then became something that sort of school children used to mock each other, which shows the potentially negative power of Blue Peter, which is also funny because it was the first show ever to record 0 views on terrestrial television.
Oh, that's quite sad.
So I'm not saying it's all bad, but karma.
It got 0 terrestrial
views across. So to count as a view, I think it's 30 seconds of consistent viewer time by a television, and there was one episode back in the 2010s, I think, that got 0 people watching it.
Wow.
Impressive, huh? Which is probably going to end up with it being viewed on iPlayer and online and being quite popular, because people will want to watch the episode that got no views. But I digress.
What was happening at the same time was like the World Cup final or something.
Maybe, yeah. But which one do I want to watch more? So what's spasticity?
Here's one I did earlier.
So what spasticity actually is, if you imagine that you're going to see a doctor and they get you to sit on the edge of the bed and they hit your knee with a hammer and your leg kicks out, right?
It's a nice feeling, that.
Yeah, I kind of like it. Some people
like
hate it, but I find it quite pleasant.
So in medical school, I gave myself tendon issue, so inflamed tendon, because I had a tendon hammer, and when I was at home, I was just continually doing that to myself for about an hour.
I think I'd do the same if I had the hammer as well, yeah.
So this jerk reflex, this stretch reflex, is an example of tone. But tone is basically your body's natural state of readiness in your muscles. So it's what gives you enough strength in your muscles to, for example, stand up to maintain your balance, but not so much that everything's super tense all the time. So if you were really low tone, it would mean your body's muscles are not in a state of readiness, and so you would effectively be floppy.
I have a question. When you're ill, whether you've got a cold or fever or whatever, and your muscles just feel generally weak, and if you were to do a workout, that it would feel weaker and you just wouldn't be able to, lift as much or whatever. Is that tone?
No.
Probably not.
That's your body fighting infection, so where your energy resource is going.
Okay. So, and then when you're feeling, depressed, I know that it can be difficult to work out as well. Is that tone?
No.
Okay.
That's more of kind of a motivation factor. Tone, for example, would be bah! Okay, so for those of you listening at home, in the nicest possible way, I hope that made you jump a little bit, and I hope it didn't make you too scared if you were listening to us in the car.
Because I didn't react at all.
You've caused several crashes, Joe.
Immediately, when someone shouts, or when you hear a loud noise that you're not expecting, your whole body kind of tenses up. That is a really common example of tone. So
Me
your
when I
body's
see a
natural
pigeon.
readiness. Yeah, exactly. Yeah. You when you see a pigeon. And so some people, spasticity is where that level of tone remains too high to an inappropriate level. So you might have seen people, and we can post sort of cartoon examples of what spasticity looks like. You might see people who have cerebral palsy or who have had a stroke where one of their arms is bent at the elbow, their shoulder is turned inwards, so their hand is over their chest, their wrist is bent, and all their fingers are tightly curled up into a fist, and you'll find that they can't move their arm out of this position. It kind of is stuck in that position.
And when you say cartoon, you mean illustrated and not like caricatures?
Yeah, not caricatures. Yeah. I meant so we're not showing
Yeah.
individuals without consent of there. But, showing a picture of what it would look like to have spasticity.
So spasticity can occur in a quarter of patients within 2 weeks of the stroke occurring, and in 38% of patients within 12 months of the stroke.
And the things that help to predict that, it doesn't tend to develop immediately after a stroke. It usually takes days to weeks to develop, and some people can even start developing it months and years afterwards. But greater degrees of weakness, so less muscle activity, and functional impairment, so reduced ability to engage in activities like, say, washing, dressing, making a cup of tea, cleaning, all of these things, having that reduced function is associated with increase in spasticity. And one of the theories behind this is that your body needs to feel normal movement. So movement that is within the realms of your average person. It's saying that you're going to reach out and pick up a cup in front of you. Your body needs to feel that kind of movement and sensation in order to maintain the right level of readiness to do that activity. Whereas if you've got lots of muscle weakness or a lack of control and you can't repeat that muscle activity, your brain can't remember how much tone that you need to do that activity. And so because it's not getting any input to tell you how much you might need, it just keeps on giving you more and more and more and more. And so you end up in this heightened state of readiness.
So it's like a positive feedback loop.
Exactly. And so if these issues with spasticity aren't managed, what can this lead to?
Contractures. So as Joe's mentioned, that contracture, which is the permanent sort of locking of a limb, usually in a flexed position, and yeah, it can be pretty debilitating, and it can lead to disability if you're no longer able to use your dominant hand, for example. It can seriously impact people's life. It can also lead to significant pain. If you imagine if you're just tensing a muscle constantly, that's going to be quite painful eventually, isn't it? And there are multiple ways in which we can try to treat that. So one of which is prolonged stretching, including casting or splinting. So trying to gradually stretch that muscle out so that it can relax a bit more. It's a very slow process. This isn't going to happen overnight. We can use positioning, exercise, yet again, trying to stretch that muscle out, trying to retrain your brain to have that movement. We can use things like baclofen, which is a medication that helps with spasticity. We can use Botox, so not necessarily for beauty, but Botox can temporarily paralyze muscles. So if you're now able to move it, you're effectively retraining your brain again. You're sort of giving that a bit more relaxation rather than it just being constantly tense.
Yeah. And getting your arm out of that position, or if your leg is equally in a spastic position, usually legs don't tend to go into flexor patterns, they go into extensor. So you'll find people who have their sort of leg extended out, their knee almost straight and their foot pointed inwards. But if you're in that position for too long, the soft tissue structures, so the muscles, the ligaments, the tendons, actually either get stretched or they get shortened. And so if you leave this for too long, it's much harder to physically pull apart those muscle structures, those tendon structures. Whereas initially that spasticity is that the muscles and the tendons and the ligaments, they're all the same length. It's just the position that it's in that's the problem. Whereas if you leave it for months and months and months and months and things have actually got shorter, it becomes so much harder to manage. So that's why early management of spasticity is really important.
Yeah, absolutely. Early identification is key because, as you said, it's a positive feedback loop and it's not going to just spontaneously get better typically.
Yeah.
I wonder what it actually feels like when you're in that locked position. Does it kind of just feel like a really, really intense cramp?
Sometimes. One of the issues that you have most is the joint being held in an odd position and not being able to move it. If you imagine that you were laid in bed and you were laid on your back completely flat, how long is it until that becomes uncomfortable? Like not being able to move at all.
Do you mean like past the numbness?
Yeah. Like you're going to get to a point where it's quite unpleasant because you can't wiggle around.
Yeah.
So if you imagine that your arm's been held in the same position for hours, days, weeks, months, it just becomes uncomfortable because you can't wiggle, you can't get it free. And actually, one of the ways that you can help to manage spasticity kind of relates to this really. So your awareness of where your body in space is quite limited after a stroke often. So you don't necessarily feel with the same degree of sensation and knowledge about where your body is in space, so you can't necessarily tell exactly where your arm is. So vibration therapy can be used which is basically vibrating an area or vibrating the whole person. The reason why we do this is because you've got different types of nerves. So you might remember that we spoke in the past about things like C fibres. So we said these are the fibres that are responsible for a dull, aching pain. They're responsible for sensing heat. And you might remember in previous episodes we mentioned about people who eat hot food as a child can numb these fibres permanently and have a higher heat tolerance. We then spoke about A delta fibres, which are the ones responsible for a sharp pain. So say that you twist your ankle, that initial kind of sensation, that's your A delta fibres firing. You have A beta fibres, which are responsible for normal touch sensation, so non-painful touch. and we have A, alpha fibres, which feel vibration, but they also are responsible for something called proprioception, which is your body's awareness of where it is in space. So actually, using vibration can help to re-educate your brain to use these fibres properly, and not only do they then improve the sense of vibration, they also improve that proprioception, the understanding of where your body is in space, and that can help people to learn about where their arms should be. It can help their body to take that tone downwards to make the arm more movable. People are very clever coming up with these ideas, and it works quite well. It's really something we don't tend to use in the NHS that I've seen, but that has really quite strong research evidence for it.
One of the other causes of pain in stroke is shoulder subluxation. So subluxation being a partial dislocation, so like coming out of the joint slightly but not fully, and the shoulder's particularly susceptible because of the shape of the joint and how superficial it is almost, and it's just a bit of an unstable joint. Like shoulder dislocations are quite common. It's one of the most common dislocations you'll see.
Yeah.
And
Especially when you do the thing with your arms.
If you have a look on our social media, I think is it?
I think it's on our Patreon.
It's on our Patreon. Yeah, you might see me doing something very strange with my shoulders.
He's got amazing range of motion.
Yeah, and this subluxation is most common approximately 3 weeks after hemiplegia, so one-sided weakness or inability to move, and it occurs between roughly 1 in 6 and 4 in 5. So like that's a wild range, but potentially the majority of people can have shoulder subluxation who have hemiplegia.
Yeah.
And it really depends on what study you look at or what figures you're looking at. And the main factors that contribute to this are, as Joe's mentioned multiple times already, lack of proprioception, so not being able to feel your joint in space, flaccidity, so if you've got hemiplegia, you're not able to move your arm at all, you lack of tone.
And that's exactly opposite to spasticity, is flaccidity. It's that loss of tone completely, where you've not got any kind of readiness in the muscle.
Yeah, so you also get muscle wasting with that longer term.
Yeah.
But that's neither here nor there. Poor positioning, so not putting your arm in the right position at rest. Mishandling, so if somebody was getting help out of a chair or what have you, and they're pulling their arm in a strange way, lead to partial subluxation, particularly if you can't then tense your muscle because it's flaccid and sort of,
brace against it.
Brace against it, yeah. Gravity.
The biggest enemy of shoulders.
It's the biggest enemy of me. Oh, God. That and stairs. It's when I'm trying to fight gravity that it's at worst.
We know that very well.
Yeah, and atrophy of some of the muscles of the rotator cuffs. That's the main group of muscles that help move your arm and shoulder.
They help to lock it in place, because your hip and shoulder, back when we were four-legged creatures, looked quite similar in their structure. So they were designed to be a cup with a ball in it, like a ball and socket joint. But the hip socket is quite deep, so the ball's got lots of room to move around. But because of the edges of the cup being a bit bigger, it's limited in its range. You can't move your leg as freely as you can move your arm. You don't have the same degree of range of motion.
Yeah.
Whereas the cup of the shoulder is a lot shallower, so you've got much more movement in your arm, much more room for it to move, but it means it's a lot more unstable, so you rely on these soft tissue structures like muscles to hold it in place. And if those muscles aren't getting any activity, the joint starts to slide out.
Talking about those cups, it always reminds me of one of my lecturers in medical school, who was very, very, very posh, and he'd always say, "And as we all know, acetabulum comes from the Latin for vinegar cup."
Oh, really?
Yeah.
Oh, because acetic acid.
Yeah.
That's very interesting.
Yeah. But a little bit interesting, not very.
Very interesting to me. I'm not sure who else gives a shit, but...
My lecturer.
Yeah, clearly. So, in terms of who this affects, it does affect people with both hemorrhagic and ischemic strokes, but it tends to be more common in those hemorrhagic strokes where people have had a bleed. It tends to be more common in those with lower function in that limb. So again, those people who aren't able to use those muscles are going to be the ones who have that greater degree of sublux. And also as well, female patients tend to present with more common subluxation than male patients.
Perfect. Yeah, and the way that we manage this is electrical stimulation, which reduces the subluxation distance, so like narrows that gapping from the partial dislocation. Taping, so this helps to reduce pain during activity. Steroid injections can be beneficial for pain, particularly it improves shoulder abduction, so moving your shoulder out like if you was going to chicken wing, for example. And slings. This helps with positioning more than anything.
But the only issue is, as well, is that when your body's relearning where it should be in space, holding it in this pattern where it's flexed can actually go the opposite way, and when your body starts to recover, it tells your body that a bent position is normal, and it makes it hard again, so you can go from having low tone to having high tone. So it's stroke rehab is a very...
vicious cycle.
Yeah, there's a fine balance to be struck, and it's a very hard balance to strike. When we speak about electrical stimulation as well, I think it's worth thinking about... I don't remember what his name was. There was the person who plugged electrical wires into a frog's legs back when people were like discovering electricity and how it worked and stuff, and he was like, look, it moves.
Yes, I can't remember.
Yeah, but you know who I mean.
Yeah.
There was a dude who stuck electrics into frog muscles.
Was it GS boys with their stanky legs?
It was the stanky leg, yeah. The frog stanky leg. But the way in which this works is very much the same way. You're trying to give electrical activity to a muscle to force it to work. You don't tend to give it to people who have no muscle activity, because then you're basically just electrocuting someone. What you're doing is you're trying to take existing muscle activity and add a little bit more to it. So you've got to be selective about how you apply the electric currents, but say you've got a little bit of activity in your shoulder, they give extra stimulation to get those muscles working more, to get your brain used to using the muscles, to get the muscles working more.
So next, let's go on to CRPS, Complex Regional Pain Syndrome, which occurs in nearly 20% of patients. Now, with CRPS, we're not really sure how it works, but it can present with autonomic, sensory, and motor abnormality, where there's two types. Type 1, which is 90% of the cases, where there's no clear evidence of nerve damage. And then there's type 2, causalgia, where there is clear evidence of nerve damage.
I quite like that. It sort of sounds like a made-up word, causalgia.
Yeah.
We can see a cause for the pain. Let's call it causalgia.
Which literally will translate to cause of pain, won't it?
Yeah.
So both of these types present with sensations of burning pain. So that's kind of your sensory abnormalities. In terms of autonomic, that's kind of your body's automatic functions, so your heartbeat, your breathing, things like that. And in terms of your autonomic function, you see changes in skin temperature and colour. So you might see someone with like one normal looking hand and one purplish, swollen, cold hand. And again, we don't really understand why this is, but we tend to see this with CRPS patients. You might get disruption of hair and nail growth. So you might have people with like either no hair growth in an area that should have it, or too much hair growth, and we again don't really understand that, but these are kind of some of the signs.
Too much hair's alright, but the nails thing really freaks me out.
What if you have like too much
really long
growth?
nails? Yeah.
But also you might see sort of swelling of the affected joints as well. So it tends to present in the hands. Hands and feet tend to be the most common places for CRPS, and it can affect motor as a result. So your movement of the hands, if you've got swollen, painful hands, it can impact your ability to use that area of your body.
So risk factors for CRPS can include a shorter time since the stroke occurred, shoulder subluxation, frozen shoulder,
which is basically where, for some reason that we don't really understand, the muscle and soft tissues around the joint thicken and prevent it from moving.
Yeah.
That does tend to be for patients who have a stroke who already had a developing frozen shoulder. That's not a common kind of... and the same with things like entrapment neuropathy, so anyone who's got a trapped nerve, anyone who's got damage to a brachial plexus, if they've had a motorcycling accident in the past, sometimes a stroke can trigger CRPS, but it seems to be more common in people who already had these kind of things.
What are some other risk factors, Josh?
Lower respiratory tract infections, UTIs, depression, coronary artery disease, and also malnutrition.
Yeah.
Oh,
and why these things? This is the problem with sort of studies that look at all of these different clinical factors and how much people develop CRPS, is that they tell us that there's a statistical likelihood that having a UTI, urinary tract infection, increases your risk of having CRPS, but the causal effect of that, or the reason why it might contribute towards it, is what we don't understand. So I think we find that with a lot of things about the brain, is where the brain is involved, it's so complicated and the body is so complicated that we just don't really... We might be able to find correlations and to have a little bit of an idea about what's going on, but really there's so much more for us to discover.
as complex as the brain is, it's absolutely marvellous. There's concepts that both Joe and I learned in university during our first degrees called neuroplasticity, which is especially pertinent in terms of stroke. So after damage from the stroke, the brain can actually almost regenerate pathways. So new pathways are formed to complete tasks. So this is why rehab activities are so important, because as Joe mentioned, if you're not used to doing those exercises, you lose the ability to do it. However, if you reinforce those important compound movements and very fine motor controls, your brain will try its best to strengthen those connections.
Yeah. And so if you imagine that your brain is a car journey, so you doing a function, say that you being able to put on your socks is a car journey, and the stroke causes you to lose the functions that you need to do that. So let's say that the M1 is closed, and that was the route that you needed to take. And so initially what your brain will try to do is find existing pathways that it can use to work around that. So you might have to take a really circuitous route, and your brain's trying to compensate, and it's using functions and movements that it wouldn't usually do to try and make this work from a functional point of view. But say that the M1 was closed permanently, a new road might be built that might be just as efficient, but your brain has to take a long time in terms of building the new road in order to get that to be as efficient as the original path was. And so your brain is just trying to find these new pathways, and that might involve new neurons actually forming. It might involve sprouting of parts of neurons, so different neurons that didn't previously talk to each other start talking to each other. It might be that the connections between the neurons, called synapses, either get weaker if they're ones that we don't want to use anymore, or they get stronger if we want to use them. Or it might be that your brain's mapping, so how it understands itself and how it portrays your body and where your body is in space in your brain, there can be remapping of this to help your brain relearn.
Wow. I wonder when that happens, when it recognises, this pathway being non-functional anymore.
You're not using it. If you don't use it.
But is it temporary or permanent? How does it recognise that?
Depends. So you will get areas in the brain called the infarct area, which is, especially with ischemic strokes, you get the infarct area, which is the area of tissue that dies as a result of the stroke. And then you get an area...
Penumbra.
The penumbra, which is the area of at-risk tissue. So that's the area of the tissue that if it's not managed properly, and if you don't encourage recovery of the brain, that area of tissue might die. And so you might lose all the pathways associated with it, but actually with appropriate medical and rehab management, you might get those areas back. So those pathways might be temporarily closed, whereas the ones through the infarct area, the dead tissue, they ain't coming back. So that's why your infarct area is that the road is permanently closed, your penumbra is that the road might permanently close, but it could also reopen.
Infarct.
Yeah, so has the bridge fallen in? Has the bridge collapsed, or is it just upletting a boat through?
Yeah.
Interesting.
So there you go. That's why everything that's done towards a stroke, and I know we've touched more on the pain and the management of pain, but generally the management of a stroke is trying to exploit this neuroplasticity and trying to use this to regain as much function as possible. And obviously, there's the Stroke Association in terms of charity support, but I cannot recommend enough, and we'll put links to this in the show notes.
Our Patreon.
That too. But there's the Post-Stroke YouTube channel, which is an occupational therapist out in the States who basically makes hundreds and hundreds of videos about stroke, about how it happens, how it works, about different ways that you can rehab. She's got great exercise programs on there. She's got advice on how you can train yourself to improve your brain's recovery. And really, we think she's the perfect place to go if you want an easily digestible way to learn more about how a stroke can be treated.
Sounds like a very good, useful resource.
It is. And it's so good, in fact, that I don't want to distract you with a book review. So that is the equivalent of our book review today. I want you to go and have a look at that. Take 5 minutes, go and watch one of her videos, and you'll see how amazing she is.
Fantastic.
Best homework ever.
Well, that was quite a heavy episode, full of science and wonderful information. So I think that's us done, isn't it, before we talk ourselves to death?
And if you have any questions about anything you've heard on this episode or any other, you can get in contact with us at paininthepodcass@gmail.com. Please send in your questions, your feedback, your thoughts, your quandaries.
Or if you just want to send us some abuse as well.
Oh, I did have a question for the listeners. In today's episode, we've discussed a lot of risk factors, and with something like stroke, it's something quite serious, and there are some very realistic and kind of attainable methods to manage or preventative measures that you can take, such as living a healthier lifestyle, etc. But when it comes to, I guess, things like strokes and other conditions, I wonder, those of us who are non-medical, how we actually think about these things. Because I still think that strokes are something that can happen to anyone whenever, and they're fairly unpredictable, even though we've listed out all of these risk factors and preventative measures. And so I want to know if the listeners also have a similar mindset about these kinds of things, because that can be quite either scary or a nice ignorance is bliss kind of way to live.
I think hopefully this episode will have helped to contribute to people's understanding in a way that they're now more aware that you have more control than you think. Because I agree, I think we think of things like strokes as being out of the blue and unpredictable, a bit like an earthquake, really.
Yeah.
But actually, you have so much control over your future in terms of your stroke risk, and so hopefully you're a bit more tooled up and aware now about actions you can take in your own life.
Yeah. Let us know. And with that, I'm going to say goodbye.
I will also say goodbye.
And I will also say toodle pip.
Nice. I think Josh just nearly had a stroke then.